So what we call the aberrant middle lobe in the left lung? Lingular, right? Absolutely right. And the right lung is, compared to left lung, it is slightly heavier. So basically this respiratory tract starts from nose and mouth, and it will end till the alveolar sac. So can any one of you define what is the upper airway and what is the lower airway tract? Till what point we tell this is upper respiratory tract infection? Yeah, upper respiratory tract. Till that one we can call that is lower respiratory tract. So you can perhaps the sliders. I will show you. So the nose, from that one the air will start, right? After that there will be pharynx, hypopharynx, pharynx, and pharynx followed by the larynx. So the airway till the larynx, right? We call that upper airway or upper airway diseases. Whatever pathology happens to this tract, we call that is upper airway tract. And beyond the larynx, that is from the trachea, principal bronchi, that is right and left bronchi, followed by the primary bronchiole, secondary bronchiole, tertiary bronchiole and terminal bronchiole, followed by the respiratory bronchiole, then alveolar duct, right, followed by alveolar sac. So from larynx till alveolar sac is the lower respiratory tract, right? We have demarcated here also, pointed here. Upper airway consists of from nose, mouth, pharynx and larynx. Till this part we call this as the upper airway. And the lower airway consists of the from trachea followed by the principal bronchi, right and left, followed by the bronchioles, that is primary, secondary, tertiary. Why I am teaching you people? Because these things are important to know where is the pathophysiology, right, happening. So there are bronchioles that are primary, secondary, tertiary and terminal, followed by the respiratory bronchiole, alveolar duct and alveolar sac. So what is the functional unit of kidney? Glomerular, right? So like that only, what is the functional unit of lungs? They are acini, right? They are acini. And what they consist of? They consist of the respiratory bronchiole, alveolar duct and alveolar sac. Remember this, right? So the functional units of the lung is acini. So moving on. So what are the structures that you will see in normal histology also? That is also important, right? So what you will see in a normal histology of a bronchus? They are there, right? That will be in the alveolus, right? And so I will draw here a diagram also, so that you people will understand the pathology, pathogenesis also, right? So the normal bronchus. So bronchus will have a lumen, right? And that lumen will be lined by epithelial cells. So can anyone tell me what is the name of these epithelial cells which lies to the bronchus? That are ciliated columnar epithelium, right? So there will be cilia here in the epithelial surface. you will have cilia, right? So below this epithelial layer, there will be layer of subepithelium, right? And this subepithelium contain the submucosal glands. They are normally present, right? And remember one thing also, there are few globulate cells also. Globulate cells. These are present in this epithelial lining. In between there are very minor amount, very less amount. Normally they are also present. And this submucosal layer, it contains the submucosal glands that will moist the airway tract. Remember, their secretions that will come out to the epithelial surface and they will moist the respiratory tract. Followed by, there will be muscularis propria, right? So there will be muscles. Also, there will be presence of cartilage. So cartilage will be present in the muscularis propria, and there last layer will be serosa, right? Because this histomorphology will help you out to understand the pathology of chronic bronchitis, right? So we will see. So this is similar image showing the respiratory tract from larynx to the primary bronchi to the bronchioles, followed by the alveolar sac. So in another picture, you can able to see better appreciation of this bronchiolar muscles. Also, you can see here. This is normal bronchus. Here, there is a collateral between the pulmonary veins and artery. This gaseous exchange will take place at the place of alveoli. So in normal conditions, we are also able to understand when we will see the pathophysiology. There are few connections which will form during the pathogenesis, right? I will come to these parts in detail in afterwards also. But remember, if the connections which will form in between these bronchioles, there are these MCQs will come, right? So these points are, remember, 3 points: channels of Martin, channels of Lambert, and pores of Korn. Right? So what are these? Because all these three wheels have the MCQ, 3 MCQ, different principles. So connection between the bronchioles, between the two bronchioles. So interbronchiolar channels or interbronchiolar connections, they are called the channels of Martin. So connections formed between two bronchioles, that is we call them interbronchiolar connections, we call the channels of Martin. The connection formed between the bronchioles and the alveolar sac, that is the bronchoalveolar. That is the bronchoalveolar connections. We call them channels of Lambert. And the channels between two alveoli, we call them pores of Korn. So as someone was telling, this is normal histology of the lung. You can see these are alveoli, normal alveoli, lined by type 1 pneumocytes and type 2 pneumocytes. Right? If there will be damage to type 1 pneumocytes also, these type 2 pneumocytes will change into, transform into the type 1 also. So, in today's or tomorrow's lecture, we will try to cover the COPD, that is chronic obstructive pulmonary lung disease, right? In 2 lectures, today and tomorrow. So in today's lecture, we will try 2 entities. So what are entities which comes under the COPD? Any one of you? What are entities that will come under COPD? Chronic bronchitis, emphysema, then bronchial asthma, bronchiectasis, and bronchiolitis, right? So all these 5 entities. Remember, chronic bronchitis, emphysema, bronchiectasis and bronchiolitis. Remember, 5 these entity will come under the COPD. So today we will learn about 2 topics, chronic bronchitis and emphysema. So what is the definition of COPD as per the WHO? So there is some obstruction which goes on, and in different diseases the obstruction is at the different levels, right? In chronic bronchitis the obstruction or the pathology lies at the level of bronchus, while in the emphysema the pathology lies at the level of alveolar sac, right? We will see that one. But most of the patients will have the overlapping diseases. So what is the definition of COPD? It is a common, preventable and treatable disease that is characterized by the persistent respiratory symptoms and airflow limit or alveolar abnormalities caused by the exposure to the noxious particles or gases. Most commonly it occurs due to the smoking or tobacco, right? Tobacco, smoking. So COPD is not simply a smoker's cough, but it is an underdiagnosed and life-threatening lung disease, as it is third cause of death all over the world, right? COPDs, followed by the ischemic heart disease. So as I told you, this COPD will consist of the majority 3 parts, that will be chronic bronchitis, emphysema. Bronchitis, the patients will have productive cough and airway inflammation, while in emphysema there will be alveolar wall destruction and overinflation, and in asthma there will be reversible obstruction, and it is due to the bronchial hyperresponsiveness. So COPD around 30 to 50%, 35 to 50% of the heavy smokers, they will develop the COPD over a long duration of periods, like 40 packs per year over an years, right? That will leads to the COPD in the smokers. But 80% of the COPDs, they are attributed due to the smoking only. They are more common in women and Africans. They are more liable, they are more susceptible. Other factors include pollution, that is pollution from the environment and air hyperresponsiveness diseases and some genetic polymorphism in persons. But remember, smoking is the most important factor that leads to the development of chronic obstructive pulmonary diseases in the patient, right? 80% of the COPD patients having the history of smoking. But however, around 35 to 50% of the patients who have chronic smoking history, they develop the COPD. So in general, considering the pathology, what it happens, the chronic tobacco smoke and air pollution, along with few patients who are having alpha-1 antitrypsin deficiency, we will see how this causes. That leads to the bronchial irritation and inflammation, and due to this alpha-1 antitrypsin, there will be breakdown of the elastin or the connective tissue in the bronchial walls. That leads to the chronic bronchitis, which leads to the hypersecretion of the mucous glands, chronic cough, bronchospasm, bronchial edema, and destruction of the alveolar spaces. That ultimately leads to the airway obstruction, airway trapping, dyspnea, and frequent secondary infection in these patients. And ultimately it leads to the abnormal ventilation perfusion ratio, hypoxemia, hypoventilation, and cor pulmonale. So what is the site exactly what happens in chronic bronchitis and pure emphysema, right? So in pure chronic bronchitis, the large airways will be affected like the trachea bronchi, right? We will see how that will be affected. and that leads to the hypersecretions from the submucosal glands. And in emphysema, the major pathology lies in the alveolar sacs. So first entity we will learn today is chronic bronchitis. So what is the definition of chronic bronchitis? It is defined clinically as the persistent cough with sputum, and that is for a duration of almost 3 months over at least of 2 consecutive years in the absence of any other identifiable cause. Continuous 3 months, consecutive 2 years, productive cough, that is we call chronic bronchitis. And remember, 90% of these chronic bronchitis cases are associated with smokers. This definition is important. 3 months duration, consecutive 2 years in chronic bronchitis. So as I told you, most etiological common factor that leads to the chronic bronchitis, COPD, is the tobacco smoke, over 90%, followed by the infection, followed by the exposure to irritants that leads to the irritation of the respiratory tract and gastric reflux. So whenever this irritation will occur, what will happen? The chronic smoking, air pollution, what they will cause, right? So in chronic bronchitis, this chronic irritation caused due to the smoking and pollutants, they leads to the hyperplasia and hypertrophy of the glands, submucosal glands. That leads to the oversecretion of the mucus-like substances in the submucosal glands. And these secretions, they will block the airway, right? And that causes the obstruction. That leads to the chronic cough, dyspnea, as well as sputum-like material in the cough, right? Copious secretions, right? So whatever diagram I draw here, you can remember from the normal bronchus. So what happened? This chronic irritation, substances like tobacco and air pollution, they will cause irritation of this mucosa, right? So this mucosal irritation causes the hyperplasia, because there are, as we have seen in cellular adaptation, whenever there will be injury or some irritation, the cell will undergo 5 types of adaptation. It will undergo atrophy, or it will undergo hypertrophy, hyperplasia, dysplasia, or last metaplasia. Right. So here, due to irritation or chronic smoking, the submucosal glands, they will undergo the hyperplasia and hypertrophy. So the number of glands which are there in the submucosa, they will increase in the number as well as in the size, right? So the patients who are having chronic bronchitis, if you take out the sections from that area, you will be able to see there will be increase in the thickness or increase in the size or number of these submucosal glands, right? So the submucosal glands number will increase over. What will happen? That leads to the increase in the secretions. That secretions, where it will ultimately come? That will come into the lumen. So all these secretions will come inside the lumen, and these secretions causes obstruction in the airway. That leads to the patient having cough, dyspnea, decreased saturation, right, over a duration. Along with this, there will be increase in the number of goblet cells, right? So as in adaptation, the cell will either undergo hyperplasia, hypertrophy, dysplasia, metaplasia, or atrophy. So the changes here also occur. In mucosal layer, from the chronic bronchitis patient, if you see, there will be increase in the number of goblet cell also, right? Can anyone tell me what is Reed's index? Because this is favorite question. Reed's index. How it is measured? Read index. It is the, I think I am having diagram also. Right. So what is reduced index? There will be ratio. So what we got? This is normal histology section. You can able to see whatever epithelium or this is mucosal lining, right? Followed by this is the submucosa. Normal histology section followed by this submucosa. You can able to see there are submucosal glands, right? In normal there will be number decrease. There will be very less number. But in patients of chronic bronchitis, you can able to see the number of glands are increased, quite increased. Also, you can see there are few large glands also, few small glands also, right? And so, Reed's index is the we will measure the length of this total bronchial wall. That is the denominator. And what it contains from the submucosal thickness. Submucosal thickness upon the total bronchial wall thickness. So what will happen? The submucosal gland thickness in chronic bronchitis, as there are increase in the number of submucosal gland, this thickness will increase because the number of glands also are increasing. They are proliferating. They are having hypertrophy also. So there will be increase in the thickness of submucosal glands. But the length, whatever the total wall thickness of that will be there. So compared to total wall thickness, the submucosal thickness will be increased. So ultimately Reed's index will be increased. Remember, these questions will be asked. Increased Reed index is seen in conditions, right? Emphysema, chronic bronchitis, all 5 options or 4 options out of COPD they will do. So Reed index will be increased in cases of chronic bronchitis. So I already told you, it measures the size of the mucosal glands, the area occupied the glands in the plane vertical to the epithelium as a proportion of the thickness of the entire bronchial wall versus the basement membrane to the inner perichondrium, and it is normally 0.4 or less. But in case of chronic bronchitis, it is more than 0.5. Till now everything is clear? Anybody is having any doubt? You can ask. Because this is the major pathology that will happen in chronic bronchitis. How the Reed's index is increased, right? You people know the Reed index is increased, but how exactly it increases, that is here, right? The chronic substances like smoking, air pollution, all these things leads to the irritation of the mucosal lining of the bronchi or respiratory tract. That leads to the hypersecretions or hyperplasia and hypertrophy of the submucosal glands in the bronchi. That ultimately leads to the increase in the submucosal thickness and increase in the mucus secretions. So I already covered this much part. So in morphologically, what you will see, there will be thickening of the bronchial wall by the mucus gland enlargement, and there will be encroaching of the bronchial lumen or narrowing of the bronchial lumen. There will be increase in the number of goblet cells. There are hyperplasia of the goblet cell. There will be increase in the number of smooth muscles, which may indicate the bronchial hyperactivity, and there will be squamous metaplasia also. Whatever the normal ciliated columnar epithelium cell will be here, you can able to see that if you have the HME sections, this normal ciliated columnar epithelium, that will be replaced by the squamous epithelium also. These are different types of adaptation. If you undergo hyperplasia, hypertrophy, you will have change in the form of one epithelium to another epithelium. Ciliated columnar will undergo squamous. Next. So these are pictorial diagrams you can able to see. This is normal bronchus, right? And in case of chronic bronchitis, the glands are increased. You can see here less number. This is pictorial diagram, which is what I told you here also. Similar thing here. there are some mucosal glands, and this is open airway or luminal side. You can see in chronic bronchitis, due to irritation and inflammation, there will be excess mucus which causes the chronic cough and increase the number of the mucus glands. So in pathogenesis, similar things in tabulated format. Continuous exposures to the irritant as smoking or air pollutants. That leads to the irritation of both large and small bronchi. It leads to the hypertrophy, hyperplasia, and metaplastic transformation, right, into formation of the goblet cells. And there is also inflammation and fibrosis in the bronchial walls in long duration course, over a long duration. Ultimately, what it leads to, due to increasing the number of glands and secretions, there will be mucus hypersecretion, and due to this long-standing cases, inflammation and fibrosis, that leads to the narrowing of the lumen of the respiratory tract, that is narrowing of the bronchi and bronchioles, and ultimately all these things, pathology leads to the chronic airway obstruction. So what are the clinical features that these patients will have? These patients, due to the hypersecretions in this respiratory tract or bronchi, these patients will have the productive cough, right? There will be copious secretions, sputum, right? So these patients will have productive cough, and there will be mild cyanosis, or we call them blue bottles also, right? And in long-standing cases, the chronic bronchitis commonly leads to the cor pulmonale. What is the cor pulmonale? Can anyone tell? And cardiac failure also. So due to these chronic obstructions, what will happen? Whatever the blood, as this is the heart, there will be divided into 4 chambers, right? Right atrium, right ventricle, left atrium, and left ventricle, right? So from right ventricle, this one, the blood will go towards the lung. But due to the chronic obstruction, the blood will not, whatever the portion of the blood, that will not go towards the lung, whatever normal quantity will be there, right? So that obstruction causes the hypertrophy. That leads to the, over a days, that will cause the hypertrophy of this right ventricle. So you will see the patients who are having COPD or chronic bronchitis, they will have right ventricular hypertrophy. And in long duration, they will suffer from cardiac failures also, right? So cor pulmonale, there will be increase in size of the heart. So moving on to second entity, that is emphysema. So we have seen where is the main pathology of the chronic bronchitis. As I already told you, upper airway disease and the lower airway disease. Upper airway is till the larynx, till the lip of larynx, and from larynx what starts? Trachea, right? It leads to the trachea. Trachea से क्या निकलता है? There will be right and left bronchus. From bronchus there will be bronchioles, right? What are bronchioles? They will be either primary, secondary, or tertiary. From tertiary onwards, there will be terminal bronchiole, right? Remember this sequence: trachea, bronchi, bronchioles, primary, secondary, tertiary, and terminal bronchioles, followed by the respiratory bronchiole, followed by the alveolar duct and alveolar sacs. So in chronic bronchitis, pathology lies in the bronchi, right? So their pathology lies in the major airways or big airways. What happens in emphysema? The pathology lies in the main functional unit of the lung, that is the alveolar sac. So what is the definition of emphysema? It is an irreversible enlargement of the air spaces distal to the terminal bronchiole. Remember this word. This will ask in MCQ, right? What is emphysema? So remember, distal to the terminal bronchioles. So terminal bronchioles onwards, there is respiratory bronchiole, alveolar duct and alveolar sac. So this is irreversible enlargement of the air spaces distal to the terminal bronchiole, accompanied by the destruction of their wall without obvious fibrosis. Right? So in morphology, emphysema is classified according to the location. Right? So where is the exact location of this obstruction or pathology? According to that, the emphysema has been divided. So can anyone tell me what is the classification of emphysema? What are types of emphysema? Anyone has read? Okay, no problem. I will tell you. Sure. So there are mainly 4 types. Right? First is the centriacina. I will tell you what is meant by centriacina, all that things we will cover. First is the centriacina. Second is the panacina. Third is the paraseptal of distal. And fourth is the irregular. So, again, there is one MCQ here. If someone asks, what is the most common type of emphysema? क्या हुआ इसका Okay, no problem. चलो silent. So, if the question is asked, what is the most common type of emphysema, then what is your answer? Centriacina. But when that is the answer, when the patients will have symptomatic, right? When the patient is symptomatic, when the patient is presenting symptomatically, or patient is having any clinical signs and symptoms and they are presenting, at that time the most common emphysema type is the centriacina. But in majority of the cases, in autopsy finding, what is the most common type? What we will see is the irregular type. Right? So they are usually silent. These patients will not present clinically. So suppose someone asks what is most common type of emphysema, then that is irregular. But in question it is asked, what is the most common type of emphysema presented clinically? Right? Patient presented clinically. Then the answer will centriacina. So we can see here in this diagram, I already told you, this is bronchi, then I will cover this afterwards. We will see this one. So what is the site? According to the site, it has been divided, right? So what is centriacina? As we have told, this is respiratory bronchiole, right? Respiratory bronchiole followed over by the alveolar ducts. Right? And then there are alveolar sacs. So according to the site exactly where the obstruction occurs, it has different types. So as we can see, this functional unit, if everything is enlarged or everything is affected from respiratory bronchiole, from alveolar duct till alveolar sac, we call it is panacina. Pan means everything. Right? You can remember that thing. So everything is affected. Respiratory bronchiole, alveolar duct and alveolar sac. What happens in centriacina? The central portion. There will be affection of the alveolar ducts and the respiratory bronchiole. Right? So in centriacina, the affected part will be respiratory bronchioles and alveolar duct. And what happens in the distal part? The affected portion will be only in the alveolar sacs. And irregular means irregular. Anything. it can have proximal, it can have distal, or it can have irregular involvement. So what is types? As I told you, is centriacina and panacinar. Centriacina, the central part of the acina is formed by the respiratory bronchioles are affected, and where it is commonly occur? It commonly occurs in the upper lobes, and these commonly have association with the smokers. While the panacinar, they are uniformly enlarged from respiratory bronchioles till the alveoli or alveolar sac, and that tends to occur more common in the lower lobes. These things will be asked, right? Centric acina type of emphysema most commonly affected which part of the lung, right? So that is most commonly affect the upper lobe, while the panacina type, they most commonly affect the lower lobes. Continuing that one, what is the distal acina or paraseptal and irregular emphysema? The paraseptal में क्या होगा और distal में what happened that there will be proximal portion of the acinus is normal, but the distal part is involved. That is the alveolar sacs are involved. They are localized along the pleural surface adjacent to perilobular septas area, and they are more severe in the upper half of the lung. Again, remember, paradistal or paraseptal, a distal acina or paraseptal, and centriacina, they are more common in upper part of the lung, while the panacina, they are more common in lower part of the lung. And in irregular emphysema, there will be acinuses irregularly involved, and they are associated with scarring, which resulting from healed inflammatory disease and often asymptomatic. I already told you, because most of these irregular emphysema cases occur in autopsy finding also. These patients will not present clinically. Anything doubt about the types? You can ask now. So how many types? There are only 4 types of the emphysema: centriacina, panacina, paraseptal and irregular. Most silent and most common condition is the irregular type. But patient most commonly presenting clinical signs and symptoms, that is centriacina. In centriacina, the part involved is respiratory bronchioles and alveolar duct. Right? In distal, the part, and in panacina, everything. That is functional unit of the lung. That is the alveolar acina, what we call from respiratory bronchiole, alveolar duct and acina. Everything is involved. So what is etiological factors and pathogenesis in emphysema? The inhaled cigar smokes and noxious particle causes the damage and inflammation, which result in the parenchymal destruction and airway diseases. So this is diagrammatic forms. So tobacco, what they causes? The formation of the reactive oxygen species or free radicals. Along with this, there will be production of the interleukins, leukotrienes and tumor necrosis factors that leads to the activation of these neutrophils, and these neutrophils secretes the elastases, right? So there are 3 things: proteases, elastases and trypsin, that all in normal human conditions So there are 3 names here, right? One is proteases, second is elastases, and trypsin, alpha trypsin. So counter regulatory to them are anti-proteases, anti-elastases, and anti-alpha 1 antitrypsin, right? So counterpart will be alpha 1 antitrypsin. In normal human conditions, all the 3 they are balanced, right? So they will have equal proportion. So the ultimate effect will be null. Both are in equal proportions. But what happens due to chronic smoking and pollutant substances? The levels of these anti-substances that will down-regulate the degradation of these elastases, elastin fibers, they are down regulated. So ultimately there will be destruction of the tissues, that is the elastic tissue in the airways, right? There will be elastic tissue in this submucosal layer, there will be smooth muscles and elastic fibers that will be destructed. So that destruction leads to the alveolar damages and it leads to the emphysema. There will be dilatation of the air spaces. I will show you another. Right, so same thing here in pathology, smokings and air pollutants along with some genetic predisposition, patients with alpha-1 antitrypsin deficiency. You might have seen that condition also. That leads to the oxidative stress and increased apoptosis and senses. Along with that one, inflammatory cell release and inflammatory mediators and proteases anti-protease imbalance. It leads to the destruction of the alveolar wall. So in oxidative stress, remember that one of the important genes is NRF2 gene inactivation. What is the function of this NRF2 gene? It is a transcription factor that serves as a sensor for oxidant in the alveolar epithelial cells. So what happened exactly with the tobacco smoking? The nicotine and its derived, the binding to the nicotine acetylcholine receptor on the bronchial epithelial cells.